Well, good afternoon, everyone, and thank you for coming. It's my pleasure to introduce Dr. Bill Yasnoff. Bill is the founder and managing partner of NHII Advisors, based in Arlington, Virginia. He also holds faculty positions at 3 major universities. He has a long and distinguished background in work relating to health informatics and health information technology. He held positions at the Department of Health and Human Services, the CDC, and many others. His educational background includes an MD from Northwestern, as well as a PhD in computer science, also from Northwestern. His current research interests are also manifold. They focus on linking information to practice, spanning basic science research in these applications and linkages, system deployment, and national leadership. We are truly privileged to have Bill with us today, and thank you so much for coming.
Thank you for that kind introduction, and let me get started. So I'm going to talk with you today about the evolution of the learning health system. And I've divided this into 5 of what I call chapters that basically correspond to decades. And I'm primarily going to focus on things that in each of these decades that I was involved in. I want to say at the outset, I don't mean to imply that these are the only things going on in the evolution of the learning health system, but obviously they're the projects that I'm most familiar with. And also, I'll just let you know in advance that I will spend most of my time talking about the current decade. So we're going to go pretty quickly through the history. So starting in the 70s, we've always had, in my view, a learning health system. In the 70s, this learning health system was not exactly what we would hope it could be. Patient care was based on incomplete paper records, and the knowledge applied to patient care was in the head of the clinician. And we also had research consisting of clinical trials and case reports that got into the published literature, and the dissemination of that research was dependent on clinician education and, most importantly, clinician memory. And so the information flow in this old learning health system basically went like this. Patient care was informed by these individual patient records on paper, typically incomplete, and by clinician memory. And the clinician memory was informed by the medical literature, and the medical literature had reports of research. And also, there were case reports that primarily were derived from individual records that also got published in the medical literature. And so this was the learning health system. This system had serious problems. First of all, it's very, very slow. I'm sure many of you are familiar with the research showing that proven successful interventions take 17 to 25 years to be implemented widely. It was very inconsistent, uncertain, and importantly, and I think one of the reasons we're talking about a better learning health system today is that it has huge missed opportunities. So to help illustrate the progress of the learning health system through these various decades, I've established this evaluation form, otherwise known as a report card. Some of you may be familiar with this. And I've given grades based on availability, completeness, and speed in 5 areas: individual patient records, searchable records for other patients, outcomes data, knowledge and tools, and publications. And you can see we're not starting with a very good record, and the 2 blanks indicate basically incompletes for those areas. So, Chapter 2 in the 80s, which I call Hints of a New Approach, I'm going to talk about two things in the 80s. The cardiology database developed at Medical College of Ohio, which was inspired by the Duke database. The Duke database was started actually in 1965 for CCU patients and was one of the earliest medical databases and is still in operation today with over 200,000 patients. Also in the 80s, I'm going to talk about AMAnet, which was the American Medical Association's adventure in online information distribution for physicians, and it was the first such national network to my knowledge. So this cardiology database developed at Medical College of Ohio was a relational database with clinical information about cardiology cases. The information was entered manually. The outcomes data was solicited by mail, not by email, by US mail from prior patients, and when things came in, they were added also manually. It was designed to answer the question, what happened to prior patients like this one, and it was used in clinical conferences to evaluate treatment options for complex cases where there was no clear literature guidance. So AMAnet, I was involved in AMAnet as medical director in the late 1980s. As I said, it was an online information service for physicians. And importantly, this was before the widespread availability of the internet, and so you accessed AMAnet via a dial-up with a modem. Some of you may be old enough to remember this technology. And it also was character-based. So that means no full-screen interface, no pointing, just a line at the bottom of the screen. So building the user interfaces was quite challenging. It had a number of services, including medical news, literature, including a clipping service, which allowed you to be notified of new literature in your areas of interest every week, which was very popular. Interestingly, the notifications were sent by fax. Drug interactions, diagnostic assistance with a tool from Mass General called D-Explain, which is still around. And actually the first nationally available therapeutic assistance programs, the first of those being Hypertension Advisor, which came from Yale, developed by Perry Miller. AMAnet actually had 40,000 subscribers nationally at its peak, so there clearly was a lot of interest in this information, but as you can see, there was no patient information here, only reference information. So the report card for Chapter 2 improves a little bit with individual patient records. At least there's a grade now for searchable records, and the other areas improve slightly. So now on to Chapter 3, Foundations. So there were a number of influential Institute of Medicine reports in the 1990s. The first of these was the computer-based patient record report in 1991. This called the computer-based patient record, which we would now call the electronic health record, an essential technology for healthcare, which is interesting because it's still not universally used. And this report was revised and updated in 1997. But the real influential report from the Institute of Medicine came out in 1999. It's called To Err is Human. This report got a lot of publicity in the lay media and really created awareness, general awareness in the public, I believe, of the problem of medical errors. And this study reported between 44 and 98,000 unnecessary deaths each year in hospitals. And it characterized those errors as systemic, meaning they were due to failures of the system, not failures of individuals to know enough, to work hard enough, but these were errors that essentially were built into the system. And I should note there was a recent publication in the last couple of years that looked at this data again and claims that in reality, there are really 4 times as many unnecessary deaths as the IOM reported. So this is a very serious problem. And this really brought the attention of the nation on this issue of health as a system and the problem with errors and how dangerous errors can be. And so I'm going to talk about 2 areas that I was involved in during that decade: immunization registries and decision support. So immunization registries were developed in response to the 1989 to 91 measles outbreaks, where hundreds of children died unnecessarily from measles because they were not immunized. And we're actually in a situation similar to that today, not quite as widespread. And the Robert Wood Johnson Foundation actually funded the early efforts with a $25 million project. And then after their early successes, the CDC came in with $250 million to fund the development of immunization registries across the country. And I was fortunate to have the opportunity to build the Oregon system called Immunization Alert, which was the first successful statewide immunization registry, which went operational in 1996. Next year will be its 20th anniversary. And that immunization registry had some interesting elements. First of all, again, 1996, the penetration of EHRs among immunization providers in Oregon was, for all intents and purposes, 0. So there was no electronic technology to collect this data. So we developed special barcoded forms that allowed the data to be collected, and essentially we replaced the standard immunization form in the chart from the American Academy of Pediatrics with a special form that had barcoded labels, such that in order to record an immunization, the provider had to peel the label off the form and then stick it on a little piece of paper we gave them, and that opened up a window so that they could actually write the immunization information. So we essentially interrupted the process in the office to capture this data with barcodes, and then that piece of paper was put in an envelope. All those pieces of paper were mailed to us once a week. We scanned them all, and that's how we got the data. The registry also included decision support, because it turns out that if a child stays on time with immunizations, the schedule is pretty simple, but as soon as there's an exception, it becomes incredibly complex. And so working with Perry Miller at Yale, we developed a tool for accurate decision support, and we provided that information to providers. And finally, the immunization registry taught me the lesson of financial sustainability. Early in the process, I went to the person I reported to in Oregon, and I said, I understand how we're funding this registry. It was funded by CDC, and I said, how are we going to sustain it after it's built? And she looked at me and she said, how are we going to sustain this after it's built? I think you need to work on that. I said, okay, I'll work on that. And what I found was, in order to solve that problem, I had to make the case that having an immunization registry would drastically reduce duplicate immunizations. Because, of course, when a child comes in and there's no immunization history, all the immunizations will be given, even if they've been given already. And it turns out that giving immunizations is much more expensive than providing information. And so the way I did this was CDC had data on the total amount of vaccine that was manufactured in the country. And it turned out that the vaccine manufacturers were producing twice as much vaccine each year as was necessary to fully immunize every single child in the United States. And so while you could argue that some of it expired and some of it was dropped on the floor and lost, there was no way that you could account for half the vaccine being lost. And so essentially I made a financial case based on saving 10% of the existing immunizations. And I took that to Oregon Medicaid. Oregon Medicaid covered about 40% of the vaccine eligible children in Oregon at that time, and essentially said, if you fund the registry, here's how much money you will save. And they almost literally wrote me a check that day. And we then went to the other health plans. And that's still how the registry is supported. So this issue of financial sustainability in healthcare systems, information systems, is very, very important. So decision support, I worked on CDC guidelines for targeted TB testing and treatment of latent TB, and worked on encoding the guidelines in computable form so they could be integrated with EHRs and produce clinician reminders, and then went on to study all the CDC prevention guidelines, and we found that about a third of them could result in clinical reminders that could be integrated into electronic records. So again, the report card for Chapter 3, improving with individual records. Now there is more activity, or some activity, in outcomes data. Knowledge and tools are a little better, publications are a little better, so things are improving. Chapter 4, which I call Informed Care, the Health Information Infrastructure Vision. So first, let me talk about the NCVHS report. So NCVHS is the National Committee on Vital and Health Statistics. This is the congressionally authorized federal advisory committee to the U.S. Department of Health and Human Services with respect to data and information policy. And that group actually coined the term National Health Information Infrastructure, defining it as a comprehensive knowledge-based system capable of providing information to all who need it to make sound decisions about health, to support all facets of individual health, healthcare, and public health. And I would argue that that definition actually encompasses a learning health system, because without learning, how can we really make sound decisions? The report also said that the implementation of the NHII will have a dramatic impact on the effectiveness, efficiency, and overall quality of health and healthcare in the U.S. And they recommended a $14 billion budget over the next 10 years. And this resulted in the work that I did that led to the creation of the Office of the National Coordinator. And so I always like to tell the story of how this happened. I was at CDC and I got a phone call, and I was asked if I would like to spend some time at HHS headquarters in DC to incubate, that's the exact word they used, incubate the NHII. And they said this was based on this NCVHS report. Had I read the report? Yes, I've read the report. And by the way, the report recommends a $14 billion budget over 10 years. And so what's the budget for this incubation that you're asking me to do? Oh, we don't have any money. No money at all. I see, very interesting. So what kind of staff support will I have at HHS? Oh, no staff. I mean, we don't have any money or any staff at all. Oh, I said. So you want me to come work on this, and there's no money and there's no staff. What are your expectations for what I can accomplish? Oh, well, we're not giving you anything, so anything you could accomplish would be fantastic. I said, fine, I accept. And so I went to DC with confidence that I could do better than zero in terms of performance, even with no resources. And by July of the following year, I was able to organize the first ever NHII conference that developed a national consensus agenda for moving forward towards the NHII. And there were 600 people there. And HHS Secretary Thompson announced the national licensing of SNOMED, the Comprehensive Standardized Vocabulary. And while Tommy Thompson really didn't understand what SNOMED was, he did, as a politician, understand what a standing ovation was. And that spontaneous standing ovation got the White House interested in national health information infrastructure. After all, this was the thing that could save lives and simultaneously save money. And so in January of 2004, the president mentioned electronic records for the first time in the history of the nation in the State of the Union message, and in April of that year signed the executive order creating the Office of the National Coordinator. Several years later, I published a paper about measuring health information infrastructure progress. And frankly, I was somewhat frustrated that there were common news stories that I would see from around the country. This community and that would convene a meeting about health information infrastructure and then put out a press release saying, we are the national leaders in health information infrastructure. So I thought it would be useful to have some objective quantitative measurement of how people were moving ahead. And so we proposed 4 key measures. First, the completeness of information. Do you have all the people in your geographic area? And do you have all their information? Who's using the information? Should be all the physicians and all the consumers. And what are you using the information for? Should be medical care, public health, quality improvement, research, and operations. And is it financially sustainable from recurring revenue? So are you funding this with grants, or have you figured out how to pay for it on an ongoing basis? As part of this work, we actually site visited 4 of the most advanced communities at that time and found that they scored only 60 to 78 on a 100 scale. These were the most advanced places, and so concluded that much more work was needed. Of course, I would be remiss not to mention the IOM's vision of a new learning health system in 2007. Which was designed to draw on best evidence to provide care for every patient, emphasize prevention and promotion, deliver maximum value, and add to learning throughout the delivery of care, and improve the nation's health. The overall goal being to ensure innovation, quality, safety, and value in healthcare. And finally, in 2009, the HITECH Act was adopted as part of the stimulus package. The goal was to accelerate EHR adoption, giving providers payments for the meaningful use of EHRs, and also funding state health information exchanges to the tune of over $500 million over 4 years with state matching funds. The goal that ONC uses for those health information exchanges is to facilitate and expand the secure electronic movement and use of health information among organizations, according to nationally recognized standards. I would suggest a more useful goal would be facilitate the availability of comprehensive electronic records for every patient, and that's totally consistent with the legislation which says the utilization of an electronic health record for each person in the U.S. should be a 2014 goal, which, by the way, was not met. So my grades for Chapter 4, a little bit better for individual patient records, a little bit better for searchable records, pretty much the same for outcomes, better knowledge and tools, and publications about the same. So now we're going to focus on the current decade, and some of the material I'm going to talk to you about comes from an article I wrote in JAMA in 2013. And I want to go back to this learning health system information flow diagram. So the goal, the learning health system that we want to achieve, will have electronic patient records and a searchable patient record repository. And that searchable patient record repository will feed into a repository of knowledge and tools through these various methods. And also we will have outcomes data that feeds into our knowledge and tools, and research feeding into our knowledge and tools. And then the way we apply that knowledge to patient care is through decision support that's informed by those individual electronic records and is available at the point of care. And so, and also the knowledge and tools, of course, will both take from and contribute to the medical literature. So what I'm going to focus on is an essential component of this information flow, not the only component, but an essential component, which is a searchable patient record repository, which I would argue is fundamental to a learning health system. So the goals of health information infrastructure are, as I said, comprehensive electronic patient records when and where needed, both individual and in the aggregate for research and population health. So how do you get that? What do you need? First, all the information has to be electronic, so all providers must use EHRs. but you also have to have a mechanism to bring together the scattered information for each person, a health information exchange. And so I would say there are a number of challenges here. I've stated them as 5 challenges, and I'll discuss each one. First, there's the privacy challenge. You want to assure that there's only authorized access to these records, but who does the authorization? Second, there's stakeholder cooperation. All providers must submit records. Third, you need all digital records. Paper records won't do. Fourth, you need financial sustainability. And fifth, you need security. You have to minimize the hacking vulnerability of this data. So before I go into those, I want to talk to you about a case study. My friend's 69-year-old mother, Diane, was in good health and enjoying an active retirement. One weekend, she developed symptoms of a urinary tract infection. By Sunday night, she was in so much distress that she finally called her regular doctor, who of course was unavailable. When she reached the on-call physician, he agreed that she had a urinary tract infection and prescribed an antibiotic. Diane, who was by then in great discomfort, immediately filled the prescription at her closest 24-hour pharmacy and began taking the medicine. I'll continue Diane's story in a few minutes. So first, our current health information infrastructure efforts cannot work. We're on the wrong path. And the reason we're on the wrong path is we're trying to replicate the manual process of contacting other providers directly for records. So the way this is supposed to work is that the clinician contacts the health information exchange, which has an index of where that patient has records. And then queries go out to all the other EHRs where the records are. We wait for all the responses to come back, assemble them in real time, and then deliver this supposedly complete record to the clinician. There's a patient encounter, and the new information is stored in the clinician's EHR. And this is essentially the reflection of automating the current process for getting records. So physicians, in their desire to have this be electronic, are imagining that they just have a button to push instead of having to call the other office and have the records faxed over. But it turns out this architecture just doesn't work. First of all, it's complex and expensive. All the EHRs have to be online 24/7 to respond to queries. You have to reconcile those records in real time without any manual intervention because there's no time. This really requires a unique patient identifier to make sure that you get the right records together, and this is both politically impractical and a huge threat to privacy. And you also have to have an expensive 24/7 network operations center to monitor all the contributing EHRs and make sure they're online. You also have increasing errors with more data sources, and I published a simulation study a couple of years ago showing that if you have centralized records, basically your error rate stays the same no matter how many sources of data you have per patient, whereas if the sources of data are distributed, your error rate goes up in a linear fashion. And this is just simple math. If all the nodes have the same error rate, so if all the nodes, for example, have a 1% likelihood of not producing data, when you have multiple nodes, what happens? The errors add up. Whereas if you have only one node, you always have a 1% chance of error. Most importantly, you can't search the data in this kind of a system, because you have these distributed records. So when you want to search them, you have to retrieve them and search them sequentially. So you have to retrieve record 1, search it, retrieve record 2, and search it, and that is just too slow to be practical. The solution to this, I would argue, is what's called a health record bank, a secure community-based repository of complete health records where access to the records is completely controlled by the patients or whoever they designate. Think of these as electronic safe deposit boxes. The information about care is deposited once when it's created, and this is required by HIPAA if the patients request it. And you can build a business model that allows EHR incentives to physicians, ongoing incentives that will help to make and keep the outpatient records electronic. And it's simple and inexpensive to operate, and I have a video to show you about this.
Imagine you or someone you care for is rushed to the emergency room and might even be unconscious. Without important medical history, lives may be in danger. Does the emergency room doctor have all of your up-to-date personal health information? Do you? How can you or your doctor get it immediately? If you're like most people, your medical records aren't readily available to you or any doctor. Today, wherever you seek care, a record is left behind. A record you and your other doctors can't immediately access. Until now, no institution has been available to automatically receive and securely store your records and make them easily available when and where you need them. Now there's a way, with health record banks, a secure approach to storage where you alone control access to your health information. Think of it like a digital safe deposit box. When seeking care or in an emergency, you authorize an information withdrawal, giving your doctor access to some or all of your records. When care is complete, new records are deposited, and the information can be used to automatically complete time-consuming forms. Health record banks make good sense. You alone control who accesses your personal, private health records. Records are stored in one location and automatically updated when you receive care, anywhere in the world. Your information is safeguarded by the most secure data protection and encryption methods. And with multiple banks available, the choice is yours. Take control of your health records today. This message brought to you by the nonprofit Health Record Banking Alliance, promoting and supporting the development of health record banks.
So the architecture of a health record bank is very, very simple. The clinician inquires for the patient record is provided, the encounter occurs, and after the encounter is finished, the new records are deposited and are immediately available for use. The rationale is this is operationally very simple. It enables value-added services, which, as you'll see, are quite important for sustainability, as well as research queries. Patient control enables trust and privacy, and also forces stakeholder cooperation because of HIPAA and the requirement that if patients request the record, it must be provided, and it must be provided electronically. The low cost facilitates business models, and you can create a business model, as I'll show you, that can fund EHR incentive options, such as paying for deposits or providing internet accessible EHRs. So I did a pilot health record bank a couple of years ago and wrote it up in this article in Methods of Information in Medicine from last year. And I'll show you some of the information from that publication. So how do health record banks create value? So you provide free or subsidized EHRs for physicians, which provides more complete electronic record information and enables physicians to provide better patient care. And then the physicians recommend to their patients that they sign up for health record bank accounts. The accounts themselves are free, but this enables delivery of optional services with compelling value to patients, and that provides revenue. So here's an example of a business model with 1 million subscribers. You can operate a health record bank very nicely for $6 per person per year, $6 million, probably less. And you can provide cloud-based EHRs for every outpatient provider for that 1 million patients for $10 per person per year. And in terms of revenue, you're looking at about $3 per person per year in advertising to patients, or you can have an option for the patients to opt out for a small fee, and about $18 per person per year for reminders and alerts, which I'll come back to, and about $3 per person per year for queries. So you're looking at $24 per year in revenue, $16 in costs, and you see it's quite profitable. So let me talk about those reminders and alerts, because that's clearly a big source of revenue. So in order for these so-called apps to be of value, they have to be very compelling in order to get patients to pay for them. So the first example is this peace of mind alert. The way that works is if your health record bank account data is touched by an emergency doc, your loved ones are instantly electronically notified. So this is a AAA-like application. It really is peace of mind. And at $20 a year, pretty much everyone I talk to who has disposable income says that's a no-brainer in terms of a purchase. Preventive care reminders, so I call this Prevention Advisor. Based on your demographics in your record, you would get reminders about all the preventive things you need to do to maintain your health. Not everyone will pay for that. Third-party payers should pay, but not everyone will pay for it, but some people will pay $20 a year for those reminders. And then finally, medication reminders, and here I'm talking about refill reminders. And so the good thing about the refill reminders is that for brand name drugs, Forma will pay for those. And so you can offer those free to consumers. So just these 3 apps, and of course you would open up an app store that was allowed all the developers from the Health 2.0 community to put their apps in as well. But just these 3 apps provide a $60 per year revenue opportunity, but then I discount that by saying you'll only have a 30% penetration rate. So I take the 30% times $60 a year, that's how I got the $18. So I'm not assuming everybody buys everything. Now importantly, in this business model, which as I mentioned is highly profitable, I did not assume or try to capture 1 cent of healthcare cost savings. And this is important because we've seen in hundreds of cases that trying to capture those healthcare cost savings to pay for infrastructure is problematic. So here's an example for Houston with a population of a little under 6 million. With 4.4 million in initial capital, you break even in 16 months, and your earnings before taxes in year 4 are over $41 million a year. So now let me turn for a moment to prevention and population health. So this is now a new activity that is highly incentivized under the Affordable Care Act. Providers don't do it. It's inefficient for each provider to do it. And there are also benefit externalities. The churn in members limits the return on investment for prevention. There's no incentive for long-term prevention investments because no healthcare organization knows whether you're going to be a member in 5 years, and therefore they don't want to invest in you. One potential solution to this is a collaborative community prevention organization where all providers pool resources and the community organization does prevention and population health for everyone. The problem with this is ongoing funding, continuous provider cooperation, both initially to capitalize this and annually to provide operating funds. And I would argue the incentives for this are good, but they're clearly not compelling because you don't see these organizations popping up all over the country. And importantly, you absolutely have to have comprehensive patient information to do this. So I wrote another paper last year proposing how you can link this to health record banks through something I call a Health and Prevention Promotion Initiative, or HAPPI. Note to informatics students, all informatics initiatives need a good acronym. In this HAPPI, you combine a community prevention organization with a health record bank, and the health record bank provides the information you need to do population health, ensures all electronic records. It generates revenue. In fact, it provides funds for itself and more, and in this case, the more is population health. And so by generating revenue that can be used for population health, it can align all the stakeholder interests by giving them a way to capitalize a single entity that then provides free population health services to all of them. So how does this work? So you make the key design decisions of patient control in a central repository. Patient control protects privacy, enables you to have a central repository which empowers your prevention activities, which is the stakeholder need. The patient control also ensures stakeholder cooperation, so you get the data, and that produces the benefits you want, both the clinical improved quality and lower costs, and also the reminders and alerts and research, which pays for the prevention and also pays for financial incentives that ensure that you continue to get electronic data and you reinforce the stakeholder cooperation. And the way you start this is to offer free or subsidized EHRs to physicians and ask the physicians in exchange to recruit their patients for free health record bank accounts. So finally, I want to turn to the health record bank security challenge. It's long been known that centralizing data is the best way to ensure security, and I give you this reference from 1976. This is not new information. Distributed data is less secure. When data is distributed, you have to transmit it multiple times every time you use it, and that provides for tremendous security vulnerabilities. However, there is this inherent vulnerability of a central database where you provide a single point of access to all the data and have the potential, however small, of the loss of all the data in a single incident. And as we've seen from the various breaches from Anthem and Primera recently, this is a real problem. So there's now a widespread belief that nothing is really secure. And while as a computer scientist I would argue that that's not the case, the perception is now the reality. And so the challenge is, how can you do efficient searching if you don't have a central database? So here's an architecture that does that. You store each patient's data in a central location, but you have a separate database for each patient, and each patient's record is separately encrypted. So there's no single point of access to all the data, because even if someone physically took the server, they have to break through strong encryption for each patient, which even the NSA would find difficult. The problem with this is now you're stuck with sequential searching again. So how can we deal with that? So if we have to search these records, the way we do it is we retrieve the first one, decrypt it, search it, and then go back and do the next one. And this is going to require, if you have 1 million patients, it's going to require 1 million iterations. But what if we had 2 processors to do this? Now we can do 2 records at a time, and we only have 500,000 iterations. And I bet you can guess where I'm going with this, because if you have K processors, you can do K records at a time, and now you have N over K iterations. And in today's cloud environment, you can easily get 1,000 or 10,000 servers to do this. And so if you had 1 million patients and 10,000 servers, each server now has to sequentially search, but only 100 records, which isn't so bad. So I call this architecture the personal health grid, and filed a patent application in January. Each patient's record is stored in a separate database with separate encryption. Using massively parallel searching, you can make this work efficiently. And by the way, the processors you use could be mobile phones. There's no access point for all the patient's data, even for the operator of the service. There's no place you can go and get all the data. So it totally eliminates this database in the sky security vulnerability. So I would argue that the health record bank approach plus the HAPPI population health approach plus the personal health grid is an effective solution for health information infrastructure, giving you privacy through patient control, stakeholder cooperation through patient control and ongoing incentives, all digital information through ongoing incentives, financial sustainability via apps for patients and other stakeholders, as well as that includes research, and security through the personal health grid to avoid the potential loss of all the data. And so I think we can anticipate rapid progress in health record bank development. So now I want to come back to Diane. Diane's urinary tract infection. So you remember she was taking her medicine. Instead of feeling better, she got worse and worse and finally lost consciousness. Her husband took her to the emergency room in the middle of the night, and she was admitted to the hospital. She spent nearly 2 weeks there suffering from multiple organ failure with one complication after another. In the end, the doctors were not able to save her. The original antibiotic that was prescribed for her urinary tract infection contained sulfa, which she was allergic to. The on-call doctor had no records reflecting this known allergy. Diane's husband and 4 children were devastated. With an effective health information infrastructure, she would have gotten the correct prescription and would be alive today to enjoy her grandchildren. So in summary, the learning health system used to be publications and slow manual dissemination. The new learning health system vision is that every patient benefits from and contributes to an accessible experience base. And this vision requires a health information infrastructure. It requires other things too, but it requires a health information infrastructure, and that can be done with health record banks, the Health and Prevention Promotion Initiative, and the Personal Health Grid to solve the 5 key health information infrastructure challenges. And so the anticipated results are a real learning health system and successful pursuit of the triple aim. So the question is, what are our grades going to be at the end of this decade? Thanks very much for your attention. And I'm happy to take questions. Questions? Patty.
Great talk, Bill.
Thank you.
I'm curious. Mostly what I'm seeing that you presented, and it may just be in the way that the slides came off, it looks very much like a sort of a disease-based medical model. Do you have, or have you considered, I heard a lot of physician, and of course we're not seeing that so much, you know, especially with the ACOs
Sure.
rolling out team-based care
Sure.
and team science, and also incorporating other aspects that we don't normally find in EHRs,
Right.
like environmental data, like
Yes.
geo-tagging for, you know, by zip code and the relationship to a toxic waste dump or inability to buy fresh food. So,
Yep.
so what are your thoughts?
So first of all, my apologies for using physician over and over. Of course, we're now doing team-based care, and that actually makes it all the more imperative that we have the patient information somewhere where everyone on the team can have access to all or the appropriate parts of it. This whole architectural approach actually facilitates what you're suggesting, which is the incorporation of other pertinent information into the same record. So we have patient-centric records, which could include location data, environmental data, housing data, income data, you know, other social determinants of health, exactly. And this fits in, actually I recently put a chapter in a book on health policy, which was focused on the concept of health in all policies. And this fits exactly into the health in all policies agenda. And in fact, in other non-health areas, there's significant discussion about coordinating various benefit programs because we know that individuals face a very daunting task in terms of coordinating their eligibility for various programs that we have in place. And so this model actually would facilitate coordination of all sorts of benefit programs aside from health. And, you know, increasingly we're finding that, you know, we take care of people at the end of a chain of events that starts not with some health problem, but it starts with some social problem or housing problem or income problem. And so we need, if we want to do real prevention earlier in the causal chain, we have to take into account the social determinants. So thank you for asking that.
Well, this is a very comprehensive survey, and I appreciate the emphasis you brought together at the end very nicely.
Thank you.
This last comment is important as well. Just a couple of comments. First of all, I grew up in the 60s in medicine, and I was as general when Dr. Barnett was getting rolling. So the tools that you cited as just publication and data are actually quite potent. There's a quite memorable series of 3 papers in the New England Journal, separated by 2 7-year periods, on the length of stay by diagnosis, and specifically length of stay by diagnosis for myocardial infarction and without myocardial infarction. And what was found was that there were 2 peaks with wide separation, nothing resembling that. gasoline distribution for them to stay. And leaving aside a little peak for rule out. Those who actually had a myocardial infarction stayed either 21 days or 28 days. And it was quite puzzling how they could have such a difference until it turned out there was a single variable that explained all the difference. It was very unusual. The name of the doctor. And as soon as it was said, every house officer knew it exactly.
Yeah.
Because some doctors would write in the admitting orders, likely myocardial infarction, schedule
28-day stay.
in 4 weeks if no complications, or 3 weeks if no complications, and there was no other date. 7 years later, they did exactly the same analysis, and guess what it was? 14 and 21. It looked otherwise identical, just shifted by 7 days. And 7 years after that, it had shifted again to 7 and 14. And in fact, by that time, we had the introduction of the DRGs, and the figure nationally, based on such publications, individual publications, was 9.8 days nationally for myocardial infarction. And we believe that was a major increase in quality of care and reduction of complications. So there's some good stories embedded in the old days, and with the tools that have been available.
So you were arguing for better grades for the earlier chapters, I think.
Yeah, I think it's a little like saying, what was the quality of medical care before you had drugs like we do now?
Sure.
If you did the best that's available with the tools of the time, you probably deserve a good grade.
Yeah, that's what we were thinking, it's just, you're looking backward on, gee, they didn't have these tools or that, so they got a bad grade.
Fair enough.
But,
But that's not the way you were analyzing it. You weren't asking whether they're using the tools available. You were asking, are they meeting these criteria?
Correct.
So, now,
Right.
the part that I was listening for that I don't think you touched on is there are friends here with HITECH and their megalomaniac position on control of health information in the country currently. Seems to be mostly focused on something which can be described in a single word, which is billing. Actually, better described in 2 words, called maximal billing, or maximal justifiable billing. And that's mostly what EHR seems to be about in this country at this time. And as far
Yes.
as communication across geographic areas, as we've talked with Chuck for years, I could not believe that my old buddy David Blumenthal came to Washington, having just published in 2009 an article that there were $4 billion worth of electronic medical equipment unused in doctors' offices around the country, and did nothing to foster or require interoperability in the shovel-ready approach to maximum profits for all these difficult companies. And in this place, for example, we had a bidding for introducing physician order entry. We already created a very nice web-based system here called CareWeb. We got a lot of compliments from the companies, but they were all still on client server. And Will Cerner offered us that we should buy their current client server, go back to client server, and they would learn the web-based system from us, and then they could develop a system that could then sell us again. Based on, I mean, this is how ridiculous this business has been. So I was also trying to figure out how CDC spent, or proposed to spend, $250 million for a simple thing like an immunization registry. Was that including electronic equipment in every doctor's office, or what?
No, not at all. No, that's what they spent nationwide on immunization registry development projects. I can address that if you want. But so let me comment on your comment about the state of the electronic medical record industry. First of all, I certainly agree with you that EHRs have been primarily about maximizing billing. And in fact, this is why, in my view, in the HITECH legislation was not just about getting docs to adopt EHRs, but also this idea of exchanging information so that you could have complete records, because it's the complete records where there is quality improvement and cost savings, not in the EHRs. And in fact, it's now been clearly documented that with the rise in EHR adoption, we have actually seen a rise in costs, because in our country, we do not pay for medical care. We pay for medical care documentation. And medical care documentation is improved with EHRs, and therefore the payments are higher. And this has always been the goal of the vendors, not because they're evil, but because they needed to do this in order to sell their products. In order to get physicians to buy expensive EHRs, you had to show them how they could make more money. And so this is a circle that is still occurring. And I think that as we move from a volume-based to value-based care, we may be able to break this. And this gets into a whole area of policy that I know something about, but I would not consider myself an expert on, which is the whole issue of payment. But I will say that we cannot have a value-based payment system unless we have comprehensive information on each patient, nor can we do a good job, the ideal job in taking care of them. And this is not to say that we haven't done the best we could in the past. I didn't mean to say that. And actually, I spent a senior elective in Octo Barnett's lab, so I know Octo very well. I also want to, while I'm not going to defend David Blumenthal and the high-tech approach, which is basically the high-tech approach to health information infrastructure is essentially regulate the nodes and the network will magically appear. So it's kind of like if you want to have a telephone system, you want to create a telephone network in the United States, you would incentivize people to buy telephones and regulate the telephones and expect that the central switching stations would just magically appear. And yes, and of course when I give the analogy, it's funny, but that's really what the strategy was. So, but I will say that Dr. Blumenthal did write an interesting article in the January issue of Journal of General Internal Medicine, where he strongly endorsed patient control of records. So I want to give him some credit for coming around to that perspective, which I've been advocating for many, many years. With respect to the $250 million that CDC spent on immunization registries, this was largely can be ascribed to the actions of Congress. So Congress specifically prohibited the development of anything beyond state registries. And CDC interpreted that as requiring independent funding of all these different efforts. And so essentially what CDC did is they paid to independently develop registries in all 50 states. Now, they did have conferences where people exchanged information, and I attended many of those conferences. But you would certainly argue that it would have been better to develop an open source immunization registry and then fund the deployment of that in the various states. That would have been a better strategy, but that wasn't the strategy that they used. And so I guess I can't, not all the blame goes to Congress. Some goes to Congress, some goes to CDC. Typically, part of the problem with health IT in general, in my opinion, is that there is way too much health and way too little IT. And in particular, let me say that, and this is what I tell people on Capitol Hill when I have the opportunity to talk with them. If you consider NASA, the space agency, as an organization, you would expect, while you might not insist that a rocket scientist be the director of NASA, you would absolutely insist that as an organization, NASA should have rocket science as a core competency. Otherwise, they're not likely to be successful. By analogy, the Office of the National Coordinator should have computer science as a core competency, although I don't think it's absolutely necessary to have a computer scientist as director. And I can tell you that absolutely unequivocally, ONC does not have computer science as a core competency or really a competency at all. And there is no one in ONC now, nor has there ever been, and of course I was never in ONC, although I got the office created, there has never been anyone in ONC who has the experience of developing even a single successful large-scale health information system such as the Oregon Immunization Registry that I developed. Not a single one. So while you may be, as I am, disappointed, and as Congress is increasingly becoming, disappointed at the billions, tens of billions of dollars that have been spent on health information infrastructure to very little effect. Actually, you could argue that it's been much better than it could have been given the competencies of the persons who were doing this. So, I think our time is up, and I will thank you again for coming, and I appreciate the opportunity to be here.